This section is on adrenergic agonists. These drugs mimic the sympathetic nervous system, so remember that everything is upregulated. We're going to start by talking about the receptors themselves and then learn the drugs after that because it becomes much easier. So starting with alpha-1, whenever you hear alpha-1, think of the blood vessels. Activation causes vasoconstriction, which explains all of the uses here, including the elevation of blood pressure. Unfortunately, that goes too far sometimes, causing hypertension. Additionally, the increased systemic vascular resistance causes an increased blood pressure. So your heart attempts to decrease the cardiac output by decreasing the heart rate, causing bradycardia. So this is a reflex mechanism. Alpha-2 is used only in the CNS. There's not really a use in the periphery, so we're not going to talk about it here. Both of these drugs can be reversed with alpha receptor blockers. Moving on to beta-1. Beta-1 is on the heart, so it's going to have a positive ionotropic effect, meaning stronger rate, stronger force, and additionally improved conduction. So we use this in different types of heart failure, anything from AV block to cardiac arrest. Once again, sometimes it goes too far, so we may have tachycardia, dysrhythmias, and chest pain because we're increasing the oxygen demand of the heart by beating harder, faster, stronger. Beta-2 receptors are on the lungs. They are used to bronchodilate, most commonly in asthma. Unfortunately, this has a side effect of hyperglycemia, so it might not be great for your diabetic patients. It can also relax the uterine muscles if there's preterm labor. Finally, dopamine is not really used much anymore. However, it used to be used a lot in shock. It's on the kidneys and the heart, and it has a dose-dependent effect. So based on different doses, you're going to have different results. These beta drugs can be reversed with beta receptor blockers. We're going to move into the drugs themselves. I've separated them into two categories. They're called catecholamines and non-catecholamines, and that's based on their PK/PD. So starting with the catecholamines, these cannot be given orally because they're rapidly inactivated by MAO and COMT. They are also poorly distributed. They can't cross blood-brain barrier, and as a result of their fast metabolism by MAO and COMT, they have a brief duration of action. Additionally, they have quite a few side effects. Anything that's interacting with these two will also interact with our catecholamines. Our non-catecholamines are the exact opposite. They can be given orally, they cross the blood-brain barrier, and they're slowly metabolized by MAO, no involvement with COMT, and so they have a longer duration of action. Now, instead of sitting here and memorizing these in this order, I prefer to memorize them like this. If you draw this 5 times in a row, you will never forget it. Put them in this order and it will help you know which receptors are activated. So epinephrine and ephedrine activate all of the receptors. Norepinephrine has no beta-2, so it's A1, A2, B1. Isoproterenol has beta activation only. Now we have all these drugs that activate multiple receptors, but what if we want to target a single receptor? We need a drug for each of those. So phenylephrine is alpha-1, dobutamine is beta-1, and albuterol is beta-2. Once again, dopamine's just kind of a dirty drug, so it wants something from every category. That's alpha-1, beta-1, and dopamine. As you look at these drugs, if you remember what receptors involved in them, you know their uses. Think of epinephrine. I know that is the blood vessels, alpha-2 is in the CNS, beta-1 is involved in the heart, and beta-2 is involved in the lungs, so you know all of the results of epinephrine. The final point that I want to make about adrenergic agonists is that you'll often hear drugs that interact with alpha-1 being called pressors, and that's because they elevate the blood pressure in things like shock. However, they can cause necrosis in 2 ways. Number 1 is at the site of injection, which is called extravasation, And number 2 is in the very distal extremities, such as fingers, toes, nose. They have such a limited blood supply that by vasoconstricting them for a long time, there is some evidence that they can cause necrosis of the tissue there. So those are things to be aware of when you're using pressors.